Before we start this episode, there has been something that has really been bothering me. The reality is, if you ask 10 health professionals the best way to treat PHT, you'll likely get 10 very different answers. But what if you had a personal AI system to ask any question and have its answers precisely match the philosophy of this podcast? This is now possible with my new AI assistant. Just ask it any question and it will scan all of my content, including my previous books, podcast episodes, online courses, and stored research papers to give you the best answer. In fact, every answer it gives is accompanied with clickable links to resources such as research papers and podcast episodes if you want to dive deeper. Curious about the best exercises and progressions based on the equipment you have available? Or maybe you have a flare-up and are looking to get back on track. Or maybe your sitting just isn't improving and you want to know if you need to make any adjustments. This AI system is trained to answer anything. This service is available through a monthly subscription, so you can try it risk-free and unsubscribe at any time. Click on the link in the show notes and watch the explainer video to learn more. Okay, on with the show. On today's episode, we are looking at the latest research on PHT treatment. Welcome to the podcast that gives you the most up-to-date, evidence-based information on PHT rehab. My name is Brody, I am an online physio, but I've also managed to overcome my own battle with PHT in the past. And now I've made it my mission to give you all the resources you need to overcome this condition yourself. So with that, let's dive into today's episode. Welcome back to the podcast, everyone. First and foremost, I'd like to say thank you to Saeed, who shared this research paper with me. And I usually have a lot of alerts on my computer of the latest research to come out on certain topics that I'm interested in. But for some reason, this escaped through the net. So thanks, Saeed, for bringing this to my attention. And sorry it's taken so long for me to actually do a podcast episode on it. I do have quite a backlog of episodes I want to talk about. And so, yeah, it was a couple of months ago that this was brought to my attention. But hey, as long as we end up doing it at the end, I think it's all good. And it's good to have expert opinions and not just my opinions, because if I do a podcast with a whole bunch of episodes all just talking about what I think PHT rehab consists of, then I'm giving you a kind of a biased sample. But I think it is good to have a look at what the other experts are saying, what other researchers are saying about this particular treatment, and whether things don't perfectly align with how I like to treat it. I think it's best that you guys get each perspective. And so the paper is titled Treatment of Proximal Hamstring Tendinopathy with Individualized Physiotherapy, a Clinical Commentary. And this is a good refresher as well. I know we have hundreds of episodes on this podcast, and sometimes it can be hard to sift through and find, what are the practical things that I actually need to do? What are the right exercises I need to do? What is the guidance and what are the health professionals actually saying? It's hard to delineate from so many different podcasts, the answers that you guys are seeking. So I think this is a good paper to help be a good refresher, as well as kind of updated opinions on where the research lies on this. This is an open source paper. I'll leave a link to it in the show notes. If you don't want to go to the show notes, you can just search the title. It will pop up and you can just download the PDF. The authors are very close to home. They study at La Trobe, which is where I studied. It's 8 minutes from my house. Aidan Rich is the lead author of this paper. And, upon preparing for this episode, I reached out to Rich because we've communicated back and forth and said, thanks for this paper, I'll be reviewing it. And he mentioned that there are 3 other PHT-directed RCTs that are coming out, hopefully in the next 4 to 6 months. And so I'll keep a close eye on those and be happy to share it with you once that is released. Jill Cook is another researcher involved in this paper. If you're not familiar with Jill Cook, she is probably one of the world's most famous tendon researchers. And so I'm happy to have a powerhouse author list in this particular paper. It's 2025, so very recent, and let's dive into it. So a lot of the information within this paper, I think, would be better absorbed by you or better retained, I guess, if you do get the PDF of this paper and look at the tables, look at the graphs, look at the infographics, and there's photos of the exercises that are being described. There's flowcharts. There's a whole bunch of patient-specific stuff for you that I think you'd find really helpful. I'll try my best to relay the information in an audio format in a way that hopefully you can understand and follow along. But just so you know, that's a good resource out there. And the education side of this we'll talk about like the exercise prescription mostly today, but a good piece of the puzzle described within this paper is also the importance of education. And there is a pretty hefty supplementary file accompanying this PDF, which is all about patient education, which I plan to do as the next episode on this podcast, just to follow things along. And you can access that file as well once you look up this paper. All right. So in the abstract, this paper starts off by saying a recent systematic review of interventions for PHT reported insufficient evidence to recommend one intervention over another. The most commonly recommended treatment for PHT by experts is education and exercise. Exercise for PHT aims to restore kinetic chain function and loading capacity of the hamstring complex. The purpose of this commentary is to outline an education and exercise program developed by treating PHT utilizing principles successful in clinical trials for other tendinopathies adapted to the specific anatomical and biomechanical considerations for the proximal hamstring complex. So what they're saying is they've done a systematic review on the treatment of PHT, and the paper itself can only be as robust and useful as the papers that it finds. If there's not a lot of papers already published on proximal hamstring tendinopathy, when they do a systematic review and summarize all the previous papers, it can be skimpy in terms of what they found, and there can be insufficient evidence to draw a conclusion. And so that's what they've said. There's been a recent systematic review that has found insufficient evidence to really recommend one intervention. And so what they're doing in this paper is they're not only using expertise as education and guidance, but they're also using some frameworks and some principles from what they know about the treatment of other tendinopathies that have had a lot of research backing up. They haven't mentioned specifically, but there's been a ton of research on, say, Achilles tendinopathy or patella tendinopathy. And so you can try to find out, okay, what are the key principles that work for those tendons? How can we apply that to the proximal hamstring tendon with the considerations of the specific anatomical and biomechanical ways that the hamstring functions? So the first section of this paper is all about the definition, what causes proximal hamstring tendinopathy, and management. And so they say proximal hamstring tendinopathy can occur in active and sedentary people and presents clinically as localized lower buttock pain with activities including prolonged and hard surface sitting, squatting, and walking uphill or running. Overloading or underloading can result in tendinopathy. I talk about this a lot with my clients, and they say what causes a tendinopathy or what contributes to a worsening of a tendinopathy once I have it. And I often say it is a chronic misuse or a chronic load mismanagement. And I say mismanagement because that can mean overload and it can mean underload. Tendons like load. And so if you take that away from them for a prolonged period of time, that can further worsen your condition. But obviously we'll have the overloaded side of things as well. You'll notice in the success stories that I've had, and you might notice in your history as well, that prolonged rest doesn't really help. It doesn't help in the long term. And that's because tendons need that load. They continue by saying acute overload can result in a reactive tendinopathy with tendon swelling secondary to increased large proteoglycan content, but intact collagen structure. So I think what they're saying is there's a lot of fluid within the fibers of the tendon with the collagen fibers themselves being still quite healthy. They say continued chronic overload can lead to disrepair or degenerative tendinopathies where the collagen and tendon matrix are disrupted. If you listened to Keith Barr in a previous episode, he talks about with a tendinopathy, what we see in a healthy tendon is we see nice aligned fibers. We see nice straight fibers in the direction of the applied load. Whereas with a tendinopathy, the fibers of the collagen, which is what makes up the tendon, becomes a bit screwed up and it becomes quite messy. And so that's where, loading gets that signal of this is where I need to realign my fibers. This is the direction I need to apply my fibers in order to get stronger and I guess heal from a tendinopathy. In addition to structural changes, there is an interplay between pain and function in tendinopathy. So there can be a dance. Sometimes there can be full function, a lot of pain, sometimes not a lot of function, but mild levels of pain. There can just be this interplay and I guess this overlapping sensation between the pathology itself, the function that the tendon has, and the pain that the patient experiences. In PHT, compressive load occurs at the ischial tuberosity, or the sit bone, through activities involving high ranges of hip flexion, including lunging, kicking, squatting, and hamstring stretching, or with direct compression in sitting. Activities involving compressive load are common aggravating factors in PHT. A systematic review of interventions for PHT reported insufficient evidence to recommend one intervention over another. That's what I've mentioned before. Shockwave therapy has been shown to be effective for PHT when compared to a conservative intervention, including 3 weeks of exercise. However, the exercise approach in this trial was incongruent with expert recommendations. The most commonly recommended treatment for PHT by experts is education and exercise. Exercise for PHT aims to restore the kinetic chain function and load capacity of the hamstring complex. So what they mean by kinetic chain function is incorporating all of the components above and below the hamstring as well. So we're looking at the muscles around the hips, the muscles around the knee and the ankle, and making sure that's a very congruent, strong, robust chain. And then they're also talking about load capacity of the hamstring complex itself. So the hamstring muscle, the hamstring tendons, they need to have a restored and built up capacity to handle load or tolerate load. And that's the aim of exercise therapy. Okay, physiotherapy interventions overview. They say that physiotherapy intervention is centered around a multi-stage, progressive loading, individualized exercise program incorporating hamstring and kinetic chain exercises. They have accompanied within this paper, table 1, which is a long table of all of these stages of rehab and what's the aim, what's the cause, what's the dosage, what's the exercise itself. Very comprehensive and very well detailed. They say a significant component of the individualization is through matching exercises to each patient's sporting and occupational goals. The intervention addresses known and hypothesized mechanisms of tendinopathy and previously published guidelines for treatment of PHT and other lower limb tendinopathies. You may be familiar with the Tom Goom paper, which was released several years ago and had a multi-stage approach to the treatment of tendinopathy. It's one of the only PHT papers out there that lists, these are the exercises you should do. And a lot of people reference that paper. I've done episodes where I have seen it misinterpreted or maybe my opinions on it. I think it's great. There's generally 3 stages. You're looking at like your isometrics, which is a load and hold that static position type of exercise. And then once you are doing well with your isometrics, you then graduate to more of a movement-based or isotonic exercises like hamstring curls and bridges in and out of movement, and then graduating to more heavier and plyometric type of exercises. And so you work your way through those. And I've mentioned in the past what I've seen from a lot of patients is they start at phase 1, they start at stage 1, they do their isometrics, and they're just too, nervous, apprehensive to ever graduate beyond that stage. They just stick to their isometrics because their isometrics are fine. They don't cause any flare-ups, yet they cause a little bit of symptoms during, and so quite fearful of moving out of the isometric phase. This paper will explain something slightly differently, but to just thought I'd give you an update on sort of maybe what they're referring to with these previous papers. They say progressive loading is recommended for PHT, which again is what I highly recommend if people stay at stage 1. And as a loyal listener of the podcast, I've got a free gift for you. If you're still struggling with your hamstring rehab or wondering if you're even treating the right injury, I've created a free PHT roadmap to give you instant clarity and direction. It starts with a simple PDF checklist to see if your symptoms actually align with proximal hamstring tendinopathy, including 2 crucial diagnostic tests you can do on your own at home. This helps you to decide whether to double down on PHT rehab or head in a different direction. Once you've completed the guide, you'll unlock access to a private video where I walk you through my step-by-step rehab formula based on the latest tendon research most health professionals haven't caught up with yet. Still have questions after watching the video? That's fine. You'll also have the option to book a free injury chat with me to troubleshoot your rehab plan and tailor it to your situation. Just a heads up, this resource won't be available forever. So look for the free PHT roadmap in the show notes, click on the link and follow the roadmap from there. They're too worried or they don't have clear guidance or direction into how to graduate to stage 2, stage 3, stage 4, then that's not progressive. That's not progressive loading. So progressive loading is recommended for PHT, although there are limited data demonstrating the effectiveness of this approach compared to other interventions. The intervention was developed by the lead author in conjunction with the research team that includes a clinical and research expert in tendinopathy, referring to Jill Cook. So they say that this particular method that they're demonstrating isn't well researched, hasn't been well studied, but it is considering the knowledge of experts. They highlight the standardized education. They talk about the education around covering the diagnosis, how to monitor pain, how to manage compression, or even education around compression, and the management of high and low tendon loads. That is what we'll discuss next episode, because there's, like I say, there's a very high detailed, comprehensive educational supplementary file accompanying this paper. So we'll talk about that next time. But now we talk about the key components of the exercise program. So they say, they talk about graded hamstring strengthening. I think now would be a good time to scroll down and look at these different phases or stages. There's 5 stages in this proximal hamstring rehab protocol, but important to say that these stages aren't you graduate from stage 1, you move to stage 2, graduate from stage 2, you move to stage 3. It's sort of like this ever-flowing combination of stages, which I'll try my best to explain. Stage 1, they have called the isometric stage. And they say that the aims of this stage is to decrease pain and have also allow for a warm-up effect prior to the isotonics. So that's isotonics being the movement or what's in stage 2. And so this can be used throughout the rehab process if pain needs to decrease or if the tendon needs to warm up in order for you to execute it better with the following subsequent stages. And so the potential exercises, notice how they say potential exercises because these will all depend on the individualized approach, but they do say a double leg or a single leg hamstring bridge could be an option. A prone hamstring curl, so you are curling under weight, under load. That could be in a seated or on your stomach sort of position, but we're holding that position. Doesn't say at what angle, but like, you know, if you can hold it at like a 45-degree angle. Or they said a standing hamstring curl as an example. And so when talking about the load and the dosage, they have 30 to 45 second holds with a 90-second rest between the reps. And that's sort of congruent with the work from Keith Barr, who says that, you know, the loading, the isometric loading should be around about 30 to 40 seconds. And repeat this about 5 times. So if we do 5 lots of 30 to 45 seconds with a 90-second rest in between. In terms of dosage, they say this is up to 4 times a day for pain relief, if that is the outcome that you're wanting to desire. I've mentioned in previous podcasts about isometrics. I kind of consider them like pain medication in a way. If you do have a flare-up, or if you do have a setback, or if you're just generally more sore throughout the day, if your day-to-day pain is quite a lot, and you do get a good response from Isometrics, that being a reduction in pain, then it can be done several times a day. It's not a lot of load, so you can do it multiple times a day, not get too sore or need a lot of recovery. But yeah, can be up to 4 times a day for pain relief if required. Or you can do it as a first exercise in a larger program. And like I say, the outcome of that being eliciting this warm-up effect so you can better execute the exercises in stage 2 and stage 3, which I really like. This is what you would do. Well, it's not what you would do for pain medication. I wouldn't recommend, taking some pain medication and then doing your exercises, but you can see what I mean when I say that these exercises have the purpose, the intended purpose of, reducing pain or creating a warm-up effect that can then allow you to move along further in your rehab. They say that stage 1 is continued or in an as-needed basis as you progress through the stages and as you make things harder and harder. And they say that pain should be less than a 4 out of 10 by the end of the second repetition, which I've never seen in advice before, but this is really good because your first rep might be quite painful, might be like a 5 or a 6. But if we're doing this for an analgesic effect, and if you personally have a really good analgesic effect to these loading exercises, if your second rep of the 30 to 45 seconds diminishes yet again, if it starts at a 5, but then the second set is like a 3, and the third set is like a 2, and it's like calming down, then I guess we're okay to abide by those rules of pain being less than a 4 by the end of the second rep. If it continues to stay at a 5 or a 6, continues to stay at those high levels as the sets go on, then it's probably too irritating of an exercise. But just so you know, this is the advice given throughout this paper. Okay, stage 2 is your isotonic strength. Isotonics are just movement through load, through weight. And the aim of this is to increase strength, increase endurance of the hamstring complex, and just further adapt to heavier loads. Some examples or potential exercises would be double leg or single leg hamstring bridge. So we're no longer holding the bridge at the top like we would for an isometrics, so we're now moving in and out of those movements. A prone hamstring curl, prone meaning lying on your stomach, and a hamstring curl or a standing hamstring curl. So the same exercises done as a hold in the isometric stage can be done as a isotonic through movement in stage 2. We're looking at 2 to 3 sets of 10 to 15 reps and then progressing to 4 to 5 sets of 6 to 8 reps. As I'm guessing, as the weights become heavier, we're then doing fewer and fewer sets, but fewer and fewer reps between sets. And they mention a 1-minute rest in between the sets as well. And this is done about 3 times per week or every second day. The considerations, they say higher repetitions and lower load may be used initially if there's significant deconditioning present or if the pain levels are quite high. But as you build up strength and as pain starts to calm down, the weights increase, it becomes more challenging, and therefore the reps drop from the 10 to 15 range into the 6 to 8 range, and the sets increase to around 4 or 5 sets. That's stage 2. We then have stage 3, which is the kinetic chain. Remember how we were saying that PHT involves like the rehab of all the joints above and below, so that's an entire strong kinetic chain. This is where stage 3 is involved. In fact, there was a few things, moving away from this table, there's a few things within the paper I thought might be useful for you to know. When talking about the isotonic exercises, and particularly when given as a single leg exercise, they say that exercises are performed on both legs individually at all stages. And they say that there are motor and sensor deficits present bilaterally in unilateral tendinopathies. There has been research to show that if you get a tendinopathy on the right leg, you can then get strength deficits, sensory deficits on the opposite leg as well, suggesting that there is a nervous system influence. The whole body is starting to have some sort of reaction, and it's suspected that it's through the nervous system. So they say that unilateral or one-sided strength training results in a contralateral strength increase as well. This is known as the cross-education phenomenon. So if you were to strengthen, if you were quite weak on your right side, because that's the side you have PHT, and you so happen to get stronger and stronger and stronger on your left side, you will also get stronger and stronger on your right side. Bizarre phenomenon, but this is why, one of the many reasons why we do single leg exercises on both sides. First of all, there might be deficits from right to left, but if you so happen to get stronger on one side, you're also going to get stronger on the other. They say this is likely due to centrally mediated changes in motor control. And they also say that the resistance, so how much weight, tension, intensity, can vary between the legs. I typically don't do that, but if you're quite deficient in one side and it's way too easy on the other side for the single leg, you can make the easier side harder by lifting heavier weights. So the resistance varies between legs to elicit the desired levels of load and or to control pain levels. So good information given out there. A few little tidbits and topics that I knew back at uni, but I hadn't really remembered to execute or educate my patients on. So some very good information there. When they were talking about the kinetic chain function, they say people with PHT often have deficits in the glute maximus and in the calf muscles and in the adductor muscles. So these muscle groups can also be targeted with the intention to improve power and load distribution in those areas. And so I thought I'd hash that before going into stage 3, which is the kinetic chain. And this is to restore, the aim is to restore lower limb kinetic chain function. And this is where we start talking about things like calf raises. This is where we start talking about things like a glute max exercise and adductor exercises. They use a double leg hip thrust as a good potential exercise with different variations. It could be double leg, single leg, tandem, positions, and there's images to accompany this as well. So a hip thrust is, you may see feet are on the floor, but your back is up and resting against like a bench. And you sort of do like a glute bridge type movement, but you're starting with your shoulders elevated and resting on a bench or a chair or a box, and gets good activation of the glute max. And you can also lift heavier weights by placing it in your hip crease. You can also do standing hip abduction against resistance, or you can do a step up. And so these are exercises that incorporate the whole kinetic chain. I like step ups as my preference, but I have some of my clients doing hip thrusts. They've done hip thrusts prior to developing PHT and they're confident and they enjoy it. So I also keep those in. This can be, 2 sets of 20 repetitions if we're focusing on endurance, but can be 3 sets of 6 to 8 if we're looking at strength. And this is where the tailored approach comes in. And that's when we need to, consider the whole kinetic chain in these stage 3 exercises. We then have stage 4, which is talking about compressive load. And we educate people on what is compression. I've done several episodes on it, but it's in that educational supplementary file that I'll talk about next time as well. But the aim of these exercises is to start increasing the tolerance for your tendon to tolerate compressive load. Compressive load can be hinging, can be sitting, can be flexing at the hip or bringing your knee closer to your chest. And so we need to start getting the tendon exposed to these conditions in order for it to get better in these conditions. It's just the way we go about it. And this is where it's most challenging because I very much encourage deadlifts for a lot of my clients. And a lot of times I see people start deadlifts, it flares them up. They're too worried, anxious, nervous to restart them and they never do them ever again. And that's fair because the same reason why deadlifts are so good is the reason why it flares them up, because this is the exercise that really targets the upper hamstring. I don't really see anything else like it. And if you get the dosage slightly off, that being the weight is too high, there's too many reps, or the range of movement is too much, then that has the likelihood to flare you up. But if you really hit this sweet spot, if you really hit this dosage that stimulates the tendon to adapt without flaring you up, you've got this Goldilocks dosage, then that has the potential to recover and heal you better, in my opinion, than any other exercise out there. So yes, potential exercises in stage 4 are double leg deadlifts, single leg deadlifts, a lunge, a single leg bridge with your feet up on a step. These are exercises explained in the paper. They said that you can progress this exercise, say like a double leg deadlift, and progress with more and more hip flexion. And you can progress the single leg deadlift with more and more hip flexion. How I interpret that is through greater and greater ranges of movement. So you start at the top and then you go further and further into that deadlift. Your hips become more and more flexed. That tendon becomes more and more compressed. And we try to flirt with the boundaries of what's helpful. Where is that sweet spot? So 2 sets of 4 to 6 reps can be done initially, and then eventually progressing to 3 sets of 6 to 8 with a 2-minute rest in between sets. And this can be done around about 3 times per week. The considerations consider progressing by increasing flexion at the hip joint, and these loads that we apply should be reflective of what sport, recreational, and occupational goals or demands that you have. So we're matching the exercise, the dosage, and everything to not only pain, but also what goals, what do we need to return back to. Stage 5 is optional, pending your goals, but this is energy storage and release. This might be just more, I guess, plyometric or sport-specific drills or bounding type of stuff. This is high energy storage. Tendons love high storage and release, and needs to be done in a systematic way if your goal is to return to sport, if your goal is to return to power-based stuff. Potential exercises would be split squats, which are kind of like a lunge, but your back leg is elevated onto a bench and we're going down and up in that position. Or another potential exercise would just be sport-specific drills. So if you're playing basketball, it is returning to basketball at 50% capacity or 50% intensity. Just do some drills here and there at training, bumping up the intensity here and there, limiting the amount of sprinting, slowly improving more sprinting. It might be uphill running, it might be jumping, landing, all that sort of stuff. In terms of dosage, they say 3 sets of 8 to 20 repetitions, 1 to 2 drills, 2 to 3 days per week could be a good dosage, but the dosage will simulate the sport and the occupational demands. And so this is where it becomes like highly, highly tailored, because it's really specific to the person, and doesn't even need to be considered at all if your goal is just to return to, say, slow, easy running, or just return to sedentary work, or just return to slow, heavy stuff at the gym. So it doesn't necessarily need to be integrated into everyone's program. What else is in this paper that I've highlighted here that you'll find useful? So in terms of the individualization of things, they say that the intervention is individualized based on the treating physiotherapist's discretion, based on several factors such as their specific goals, important activities of daily living. The rate of progression through the stages varies based on the level of deconditioning, so how weak is this person, and the severity of the symptoms, the adherence to the protocol and adherence to the exercises, and the individual response to the prescribed exercises. And they say stage 5 is only undertaken if the participants, if they have reason for this high energy store and release demands. There is a section here on the combination of stages, the ebbs and flows of these 5 stages. They say the stages utilized in this intervention vary depending on the individual participant. Early stages, all these early stage exercises, are structured in a 2-day cycle where day 1 has the included prescribed exercises, and then day 2 is for your kind of like a rest day, but they have non-provocative exercises such as other aerobic fitness or upper body strength, or additional just stage 1 exercises. So if we're alternating days and going on, off, on, off, on, off, day 1 might be some stage 2 exercises, some stage 1 exercises, some stage 3 exercises, with then the next day, day 2, being some light swimming or some elliptical or some running if that's easily tolerated, or some cycling if that's easily tolerated. We're kind of having a non-provocative bout of exercise, and so you get that ebb and flow of challenging the tendon, resting the tendon, cycling back and forth. And so that can be on repeat every second day if it suits the person. They have stage 4 exercises is then added to day 1 when indicated, and participants who do not undertake running-based sports do not progress beyond this structure. They don't progress beyond stage 4. They say if stage 5 exercises are indicated, the participants move to a 3-day cycle instead of that 2-day cycle I just described, where day 1 is kind of your hamstring strengthening rehab day, where you have a combination of exercises from stages 1, 2, 3, and sometimes 4. Then you have day 2, which will include your stage 5 exercises. And then day 3 is your light, where we perform those non-provocative exercises, or plus or minus stage 1 if indicated, which is, like we say, we use for your analgesics or your pain medication type of stuff. So we have a sort of slow, heavy load day. Then we have a plyometric day, or like a store and release day. And then we have what you would call somewhat of a rest day. And you just put that on a 3-day cycle on repeat as indicated or recommended by these authors. Participants are encouraged to continue maintenance exercises upon reaching their goals. So if you've got a normal return to sport, it's encouraged to continue doing your strength training. Typically, this involves 2 to 3 exercises from stages 1 to 3, which are then performed twice per week. And I'm fully on board with this. I agree totally with backing off your rehab to 2 or 3 of the most important exercises and simmering the frequency down to just twice a week. I think that's very manageable. That helps, maintain the capacity of the tendon that we've worked so hard to build. I think that's great advice. They say rapid increases in high load activities and consecutive high tendon load days should be avoided. In some cases, specific activities such as full depth or heavy deadlifts should be avoided indefinitely. I think that's slightly extreme. So what they're saying here is rapid increases in high loading should be you should be very cautious with that. And if it is part of your goals to return to very high loading activities, you do need to do that gradually. They don't say don't do this, but they say a rapid increase in high loading activities should be avoided. But the high loading activities can be included just very gradually as you build up. And they also say that consecutive high load tendon days should be avoided. So having that ebb and flow of stimulus, training stimulus, and also recovery. We need to have that ebb and flow. And they say in some cases, full depth squats and full depth deadlifts and heavy deadlifts should be avoided indefinitely. I haven't come across a scenario yet where I'd say, okay, you never should do heavy deadlifts, but this is the author's advice. There's also a good table 2 in this paper has the combined exercise stages, the ebbs and flows of the early stages if you're not running, the early stages if you are running, and what those stages might look like. So another excellent graphic for you to go check out. It'd be very hard for me to explain through an audio format, but go check it out. And yeah, I hope you enjoy this paper. To summarize, I think it's worth mentioning that PHT is an individualized approach, tailored to your goals, tailored to your preferences, what you have access to in terms of equipment. I think my slight different lean, I guess the authors are kind of in agreement with what I have typically suggest, but I guess my approach is more start people on deadlifts, which is stage 4, but it just might be an extremely modified version. It might be 1/4 range of movement. It might be 10 pounds. It might be 3 sets of 5. So really, really light load, but for a very provocative exercise. And once we find where that sweet spot is, then we're slowly building up that exercise, as opposed to waiting several weeks for you to feel strong enough or feel capable enough to transition into deadlifts. But yeah, I suppose if you're following this advice, you'd still do that, and you're still abiding by the advice on this paper. So I think that's it's very well laid out, and I think is an extremely difficult task to write a paper on how to treat PHT, considering all the individual factors that are at play. So they've done an extremely good job of condensing this and summarizing all of this with all of the exceptions involved. So yes, individualized approach is required. There's sort of three core pillars here. We're talking about education, which I'll talk about next time, progressive strengthening, and then a graded exposure to whatever tasks you want to get back to. That might be cycling, running, those sorts of things. And we have 5 stages of this rehab. We have the isometrics, which is your holding, your load and hold type of exercises. We have your isotonic strength, so we're going through movement. We've got your kinetic chain strengthening exercises, so incorporating the back, the hips, the knee, the ankle. And we have gradual reintroduction of compression. As stage 4, we're introducing those compressive loads. And then we have the optional stage 5. If you have high training demands, we need to mimic those sporting demands as much as possible. I'll follow this up, like I say, next episode with more information from this paper, but hopefully this helps provide a refresher and maybe some new ideas on how you can adjust and redirect your program. But hopefully you enjoyed. We'll catch you on the next episode. If you are looking for more PHT resources, then check out my website link in the show notes. There you will find my free PHT 5-day course, other online content, and ways you can personally connect with me, including a free 20-minute injury chat to discuss your current rehab and any tweaks you might need to make. Well done for taking an active role in your rehab by listening to content like this, and together we can start ticking off all of your rehab goals and finally overcome your PHT.